Hello everyone, welcome to Raaonline. I'm Dr. Abinaya. I'm a consultant pediatrician. So we are in the discussion of the chapter endocrinology, and now we have come to the very important topic of the adrenals, that is congenital adrenal hyperplasia. So CAH we have discussed very deeply in our MBBS, and we have seen a lot of cases during our MD also, isn't it? And CAH is a very important topic both from the exam point of view and from a clinical point of view. So we are going to discuss this in detail and very simplified terms and with flowcharts I have discussed here. So follow this discussion, and by the end of this chapter you will understand what are the various enzymes which are deficient in CAH, and with various enzyme deficiencies what are the different manifestations and treatment. So let's start the CAH chapter. Yes, so coming to the background of the adrenal glands. So you know where the adrenal glands are located. They are the suprarenal glands, and adrenal, you know, it is divided into two. It has a cortex, the outer part, and the medulla. Again, the cortex is divided into three different portions. The outermost is the zona glomerulosa, the middle one is the zona fasciculata, and the inner one is the zona reticularis. The middlemost part is the adrenal medulla. Adrenal medulla is a part of the sympathetic nervous system. We are not going to talk about adrenal medulla here, right? Okay. So now just the basic physiology of adrenal glands and the hormones, and then we will go on to CAH. So let's start. This is the adrenal gland. This is the adrenal medulla. So adrenal medulla is a part of the sympathetic nervous system. This secretes two hormones, adrenaline and noradrenaline. Adrenal cortex has glomerulosa, fasciculata and reticularis. So the glomerulosa secretes which hormone? Mineralocorticoid. So remember, glomerulosa secretes mineralocorticoid. The fasciculata secretes glucocorticoids, and the reticularis secretes sex hormones. We should know here, the point of putting the slide here is, you should know what regulates which hormone. So first coming to the zona glomerulosa. So zona glomerulosa is a part of the adrenal cortex. It secretes what? Mineralocorticoid, that is aldosterone. So it secretes what hormone? Aldosterone. So this aldosterone is regulated not by your HPA axis, not by the hypothalamic pituitary adrenal axis. Rather, it is regulated by what axis? Renin, angiotensin and aldosterone axis, right? So how does this renin, angiotensin, aldosterone axis work? So this RAA axis, so any renal perfusion, any renal hypoperfusion. So if there is low renal perfusion, low renal sodium which is filtered, what happens? This will be sensed by the juxtaglomerular apparatus. It will start secreting renin, and renin will convert angiotensin 1 to angiotensin 2, and that will cause angiotensin 2 will cause the adrenal cortex, the zona glomerulosa, to secrete aldosterone. So aldosterone is a mineralocorticoid. It will immediately go and reabsorb sodium. It will cause potassium excretion. So potassium is getting wasted. Whenever there is hypokalemia, there will be metabolic alkalosis. So sodium will be reabsorbed, potassium will be excreted. So mineralocorticoid activity is fulfilled. Yes. So zona glomerulosa is regulated by your renin, angiotensin, aldosterone axis. Coming to the other two, zona fasciculata and zona reticularis. Fasciculata secretes what hormone? Glucocorticoid, right? And zona reticularis secretes sex hormones. So this is regulated by our HPA axis. So the hypothalamic pituitary adrenal axis, the pituitary corticotrophs will secrete the ACTH hormone. This ACTH will stimulate zona fasciculata to secrete cortisol. This will go and stimulate the glucocorticoid receptors. Glucocorticoid actions, very shortly I have mentioned here, that is, it is responsible for the catabolism of proteins. It is responsible for insulin resistance. Of course, glucocorticoids are very important as an immune response. Hyperglucocorticoid, that is when steroid levels are very high, it increases sugar levels, it increases blood pressure, so hypertension, increased appetite, and responsible for memory. Zona reticularis secretes sex hormones, so androgens going and responsible for the androgen action. All the secondary sexual characters like pubic hair, axillary hair, etc. are stimulated. So this is in general. So now we'll move on to the steroidogenesis pathway. So this steroidogenesis pathway alone can be asked in the exam both in DNB and AMD as a 5-mark theory question. So you should know the steroidogenesis pathway by heart. And so this again you can see the color gradation here. The first part, this is the mineralocorticoid pathway, followed by the glucocorticoid pathway, and this is the sex steroid pathway. So all start from which substrate? This is the cholesterol. So cholesterol is the substrate. Steroid acute regulatory protein. So star protein. So this is the star protein. So this is responsible for the transport of cholesterol in the inner mitochondrial region, and then cholesterol is cleaved to form what? Pregnenolone. So pregnenolone is then cleaved to progesterone, and further this pathway progresses. So very easily, just remember few numbers, you will be able to write the name of the enzymes. So just remember 3, 21, 11, 18. Right. So remember 3, 21, 11 and 18. So cholesterol comes inside it comes inside and it's converted into the pregnenolone by a side chain cleavage system. So after pregnenolone, you remember 3 beta. So once you remember the numbers, you will be able to write the enzyme name. So 3 beta hydroxysteroid dehydrogenase, or 3 beta HSD is the enzyme. So that converts pregnenolone to progesterone. Progesterone then will be acted upon by the enzyme 21-hydroxylase. 21-hydroxylase is the most common enzyme which is responsible for CAH, isn't it? So a progesterone is then converted to deoxycorticosterone by 21-hydroxylase enzyme. So 3 is over, 21 is over, next 11. So this deoxycorticosterone will be converted into corticosterone by 11-hydroxylase. And further by 18-hydroxylase and 18-oxidase, final what we get? Aldosterone, that is mineralocorticoid. So now the mineralocorticoid pathway is over. Just remember cholesterol, remember the star protein, it comes inside the inner mitochondrial membrane, cholesterol is cleaved. Now pregnenolone, progesterone you remember. From here 3, 21, 11, 18. So pregnenolone to progesterone, progesterone to deoxycorticosterone, and deoxycorticosterone to corticosterone. Finally, you just remember aldosterone. So this is the mineralocorticoid pathway. This is over. Next, we will move on to the glucocorticoid pathway. Again, remember these 3 numbers only: 3, 21 and 11. 3, 21 and 11. So cholesterol is converted to pregnenolone. Pregnenolone and progesterone will be acted upon by single enzyme only, that is 17-alpha hydroxylase. The 17-alpha hydroxylase will convert pregnenolone to 17-hydroxypregnenolone. It will convert progesterone to 17-hydroxyprogesterone or 17-OHP, right? So this further will be acted upon by 17-hydroxyprogesterone will be acted upon by 21-hydroxylase, will cause deoxycortisol, and then after 321 it is 11, isn't it? So that will finally cause the stimulation or the secretion of cortisol. So now the glucocorticoid pathway is also over. The last pathway is the sex hormones pathway. So here the enzyme is 1720 lyase. So from mineralocorticoid to glucocorticoid we have the 17-hydroxylase. Here we have 1720 lyase. So with this, what are the hormones? First, initially we have the DHEAS. DHEAS is converted into androstenedione. Through the enzyme aromatase, it is converted into estrone. So estrone is further converted to estradiol. So you can just remember all this. And further, this androstenediol is converted into testosterone. The enzyme aromatase is always responsible ultimately for the formation of estrone or estradiol. So just remember these, what are the hormones? 3 pathways. First is mineralocorticoid pathway, next is the glucocorticoid pathway, third is the sex hormone pathway. Remember the numbers, as I told you, you will never forget. 3, 21, 11 and 18 first in the mineralocorticoid. Then from mineralo to glucocorticoid pathway, when you are moving, remember the enzyme 17-alpha hydroxylase. Then the last pathway 1720 lyase. So roughly you will be able to write this pathway if you remember these numbers alone. Only when you remember this pathway, you will be able to understand the various manifestations of CAH types, especially. So coming to the topic of discussion, that is congenital adrenal hyperplasia. Basically all these are autosomal recessive disorder. There are biosynthetic defects in the cortisol synthesis and the mineralocorticoid deficiencies. So because of the enzyme deficiencies here in the adrenal, there will be continued ACTH secretion from the pituitary, so that will cause the adrenocortex to become hyperplastic. Okay, so that is responsible for the adrenal hyperplasia, and because of the end product deficiency, so in the first pathway is defective, there is no mineralocorticoid, no cortisol, means intermediary metabolites will be elevated. So depending on the enzymatic step which is deficient, either we can get only the mineralocorticoid and glucocorticoid, or the hyperplasia of sex steroid hormones. So the morphology will differ. So we will discuss about this in detail. We'll just move on. Yes. So coming to the types of CAH, most common type, 90% it is going to be your 21 hydroxylase deficiency. You should not miss a case of 21 hydroxylase deficiency at all. So where is the enzyme for 21 hydroxylase? It is on the chromosome 6. So next common will be the 11 beta hydroxylase deficiency. Next is our 17 alpha hydroxylase, that is shifting from the mineralocorticoid to the glucocorticoid, no, in between, that is 17 alpha hydroxylase, and after that it will be 3 beta HSD, and finally because of some star abnormalities, that steroid acute regulatory protein abnormalities can happen. So here in this presentation, I am going to discuss the first 3 alone, 21 alpha, 21 hydroxylase, 11 beta and 17 alpha I am going to discuss. So these are the most commonly asked, and you should know how to differentiate based upon the clinical presentation. Okay. In 21 hydroxylase deficiency, you would have heard there are 2 types, classical and non-classical, isn't it? So how do we differentiate both, we will see, and I am going to come back to the steroidogenesis pathway and explain to you what will happen when there is 21 hydroxylase deficiency. Okay, so this is the enzyme 21 hydroxylase. This is going to convert your progesterone to deoxycorticosterone. So the hormone which is responsible for the ultimate formation of aldosterone is not happening here. Similarly, in the glucocorticoid pathway also, ultimately for the formation of cortisol, we need 21 hydroxylase. So this is also not going to happen. So a 21 hydroxylase deficiency will present with both mineralocorticoid deficiency and your glucocorticoid deficiency. So because of here it is getting cut off, right? Here the pathway is getting cut off. So everything will go on where it will go on to the sex hormone stimulation pathway. So many intermediary metabolites will be there. Number 1 is 17-OHP, isn't it? So 17-OHP we are going to screen for the patients. We are going to get the values of 17-OHP, and the sex hormones will be increased. So DHEAS, the androgenic hormones will be increased in 21 hydroxylase deficiency. No mineralocorticoid, no glucocorticoid, excess of sex hormones. So if there is no mineralocorticoid, what will happen? Remember, go back to the renin, angiotensin, aldosterone. So if there is no aldosterone, sodium will get excreted. So number 1, there will be hyponatremia. Next, potassium is not going to go outside, so there will be hyperkalemia, there will be hypotension. Whenever there is sodium loss, there is going to be dehydration, right? So because of mineralocorticoid deficiency, you know these 4 things are going to happen. Because of the glucocorticoid deficiency, what is going to happen? Sugar is going to come less. So hypoglycemia, hypotension. Third, excess of sex hormones, androgens, androstenediones, testosterone. So this is going to affect which gender? It's going to affect the females. So virilization will be present in females. Of course, in male infants, it is only going to manifest as hyperpigmentation. So 21 hydroxylase, we have 2 different phenotypes. One is the classical phenotype, another one is the non-classical phenotype. Classical phenotype is which we see as the severe form. Okay, so there is complete absence of 21 hydroxylase enzyme. So it presents very early in the newborn age group, say somewhere between 2 to 6 weeks before the 2-month mark. They present with severe salt wasting or it can present even as a simple virilizing, but the presentation is pretty early. Non-classical phenotype, they present pretty late, so they present as a mild salt wasting, or they just present as a mild virilization form. So we will talk about the classical salt wasting type. So in the classical salt wasting type is going to be the most lethal form. Look at the baby, very dehydrated infants, newborns presenting to us, and severe dehydration, severe shock, no peripheral pulses. So you get such a picture and see the pigmentation, generalized hyperpigmentation. Look at the genitals. If it is if the genitalia is ambiguous, or if it is a male gender, if it is hyperpigmented, presentation like the severe dehydration and shock, always think of 21-hydroxylase deficiency if it is missed in the newborn screening, right? So they manifest as salt water crisis at 2 to 6 weeks of age. This presentation is very important. And yes, 21-hydroxylase will have both glucocorticoid and mineralocorticoid deficiency. Clinical feature, yes, a baby only go well for the first 10 to 14 days. After that, once they start feeding, repeated vomiting, failure to thrive, not gaining weight, presenting to you with shock. So that is a typical feature. You see the generalized pigmentation, never forget this picture, generalized pigmentation, ambiguous genitalia, and you do the labs, you find hyponatremia, hyperkalemia, hypoglycemia, and you get a metabolic acidosis kind of a picture. Yes, then you have clinched the diagnosis of a 21-hydroxylase deficiency. To confirm it, what are you going to do? Yes, again I am just showing. So this is an ambiguous genitalia. So such a picture, yeah, when a newborn is born, so when you are assigning the gender, you get an ambiguous genitalia. Immediately do not assign the gender, explain to the parents, and further screening has to be done. So this is a male. Look at the pigmentation, such hyperpigmentation here and in the genitalia as well. So female infants will be present with ambiguous genitalia, male infants will present with hyperpigmentation and salt losing crisis. So if it is a salt wasting crisis, yes, you are going to manage differently. If it is a simple virilizing type, sometimes what happens is the mineralocorticoid secretion is at a very low level, it is there. So salt wasting is not going to happen, but they will present with the virilizing type alone. So if they are present with virilizing type alone, it is going to affect which gender? It is going to affect the females, isn't it? So basically they are genotypic girls, they are XX, but because of the ambiguity in the genitalia, and if you have not, if the child has not been diagnosed rightly, they will be sometimes reared as boys, and what they present as recurrent hematuria, which is nothing but the onset of menses during their adolescence. So such presentation is also common. And simple virilizing type in boys will present as peripheral precocious puberty. So onset of adrenarche will be very early, pubic axillary hair, change in voice, acne, etc. And they are very advanced with their bone age. So ultimately their height will be compromised, resulting in short stature. A non-classical type will present very late. So non-classical means some amount of cortisol, some amount of aldosterone is still there in the circulation. But what happens is the sex hormones will be produced in the large amounts. So they present in late childhood or in the early adulthood. So because of the increase in sex hormones, they will have hyperandrogenic features. So in hyperandrogenic features, whenever the adrenal androgens are high, that will always result in secondary sexual characters. Okay, so premature adrenarche, pubic hair, axillary hair will come very early, say 8 years or 9 years. 8 years in girls and 9 years in boys. Before that, if it is coming, it is premature adrenarche. Advanced bone age can be there. In females, because of the adrenarche, it can cause hirsutism, acne, etc. and menstrual irregularities can be there. PCO, insulin resistance, etc. So these are the hyperandrogenism manifestations. So how do you diagnose? So already I told you, in the salt wasting crisis, when the baby is admitted, just recall the baby picture that I have shown. So you have done all the labs, you have found out that this is a salt wasting crisis. But how do you confirm the diagnosis? So some of the things that we routinely do, random blood sugar, electrolytes, blood gas. So this we routinely do, isn't it? random blood sugar, electrolytes, arterial blood gas. So if they are suggestive of CAH, what you should do, our next step will be to confirm by doing 17-OHP levels, do a serum cortisol, morning serum cortisol levels, do a baseline ACTH levels, and then to confirm it, what we will do, we will go ahead and do an ACTH stimulation test. We do a karyotype whenever there is ambiguity, do a pelvic ultrasound, ultimately do a genetic study and the enzyme deficiency. Okay, so starting with 17-OHP levels. So do the 17-OHP levels. It is usually done in the newborn age. We usually screen on day 3. Right, not in the first 48 hours because it can be falsely elevated or falsely low because of the maternal influence. Also, if the newborn is very sick and any transfusion or any preterm low birth weight, it can be ambiguous. So, we do it on day 3, dried blood sample from the heel prick. So, do the 17-OHP levels and it's measured after 48 hours. If it is more than 100, it is classic CAH. Say in case if it is between 2 to 100 nanogram per ml, you should do an ACTH stimulation. When you do an ACTH stimulation, if it rises at least to more than 10, then we can diagnose it as CAH. It is a non-classical type of CAH. If the 17-OHP is less than 2 nanogram per ml, it is normal, right? So, how do you do the ACTH stimulation test? We do the IV cosentropin is given, 250 microgram is the dose. You measure the 17-OHP levels 1 hour after administration of this cosentropin, which is a synthetic ACTH, and based upon the results, you can diagnose CAH. Yeah. Also, plasma renin levels can be taken whenever there is aldosterone synthesis defect. Elevated plasma renin activity is also seen. So now, how do you go about the diagnosis? Again, whatever I have mentioned only. So, just putting it across here once again. So, a newborn on physical examination. So, it's a girl by genotype, but you have an ambiguous genitalia, or a boy with severe hyperpigmentation, you have a doubt. You do a 17-OHP. If it is elevated, it is more than 100. Yes, they fall into the classical CAH. You have a normal 17-OHP level, but you have still ambiguity or hyperpigmentation. You are not convinced with this report. Do a ACTH stimulation test, do a genetic analysis. Fine. In adolescence, or if you suspect a non-classical adrenal hyperplasia, right? So, in adolescence, what are the most common manifestations? All the manifestations of hyperandrogenism, premature adrenarche, a girl with a lot of hyperandrogenic manifestations. You suspect, you do again a 17-OHP levels, and that will clinch the diagnosis. So, the goal of management will be in CAH due to 21-hydroxylase deficiency, both glucocorticoid and mineralocorticoid is deficient. You are going to replace both. So, if they present as salt wasting crisis, initially you have to manage, you have to resuscitate, you do fluid replacement, you manage all the metabolic derangements, glucocorticoid and mineralocorticoid replacement has to be done, and based upon the, if the girls present with ambiguous genitalia, gender assignment has to be done. And hyperandrogenism manifestation, skeletal maturation again is an issue. Okay, so we'll go on to the management. First is glucocorticoids. So, glucocorticoid has to be given long term. We are going to give hydrocortisone orally. Routinely, the dose will be 10 to 20 milligram per meter square per day. Because of the short half-life, you are going to give in 2 to 3 divided doses. Stress dose will be 50 to 100. That is, just remember, 5 times the basic dosage is going to be the stress dosage. Stress dosage we give when the child or when the patient presents to us with adrenal crisis, we give the stress dosage. So, here we give 10 to 20 milligram per meter square per day divided in 2 divided dosage is sufficient. Give orally. If it is available as tablet, crush them, mixed with milk or water, you can administer. First dose preferably on empty stomach just after getting up. Yes, stress dose is 50 to 100 or 50 to 75. Maximum we give 100 mg per meter square per day. So, the other one will be mineralocorticoid, that is fludrocortisone. If it is salt losing variety, we give fludrocortisone and replacement with sodium chloride. Fludrocortisone dose would be 100 microgram per day, increase up to 200 microgram per day. And even if it is a simple virilizing form, you can that will decrease the formation of sex hormones. So, even in a simple virilizing form, we have to give both. And how do you monitor? So, the goal of giving glucocorticoids and goal of supplementing steroids will be to suppress the production of adrenal androgen. So, you are giving hydrocortisone from outside, so that will suppress the sex hormones production. It will maintain the normal growth, maintain the weight gain, and it will maintain the 17-OHP levels. Although you can maintain it in the high normal, that will be maintained, and the androstenedione, testosterone levels especially, will be maintained in the normal levels for age and sex. So, the goal of giving mineralocorticoids, of course, sodium will be maintained properly. There is no hyperkalemia, no hypotension. Plasma renin levels will come back to normal. So, overall, when you give the right treatment, that is very important. When you give excess treatment with glucocorticoid, that is going to cause Cushing's. If you are going to undertreat, then that will cause virilization, precocious puberty, etc. So, for ambiguous genitalia in girls, a multidisciplinary approach is necessary. You involve a pediatric surgeon and a plastic surgeon, involve a pediatric endocrinologist, geneticist, psychologist. Our goal is to maintain the functional ability of the genitals. So, how do you do the newborn screening? So, newborn is born, already we saw the approach. So, how do you do the newborn screening? On day 3, preferably after 48 hours and before day 5. So, ideally between day 3 and day 5, not after that. Day 3 and day 5, dried blood sample from the heel prick should be done. Measure the 17-OHP levels. So, most affected newborns will have more than 10 or at least more than 50 nanograms. We have the doubt only if it is less than 10 and more than 2. Somewhere between 2 to 10 you have the doubt. And so, that's why if you go ahead with ACTH stimulation and all, you also can do a baseline ACTH, baseline cortisol levels also. So, to increase the specificity, you do a second screening, you do a ACTH stimulation test, you can also do an urinary steroid profile. Non-classical form, of course, that will not be reliably detected. Only when you have a high index of suspicion and then you have the values in mind, you will have to repeat it, you do the ACTH stimulation and only then you will identify it. So, prenatally, when will you diagnose? It is an autosomal recessive disorder. So, if the family already has a affected child, then we have to do the prenatal diagnosis. So, if the mother presents to you in the first trimester, do a CVS, chorionic villus sampling. If they present to you at the second trimester, we should advise amniocentesis, and the CYP21 gene has to be analyzed. Yes. So, prenatal treatment, our goal is to prevent virilization if it is a female fetus, right? So, you do the genetic counseling and treat if you have done the CVS or amniocentesis and the report shows that the CYP21 gene is abnormal. And we have to start the mother with dexamethasone 0.02 mg per kg per day, and has to be started right during her pregnancy, and it has to be continued. If the gender comes as male, we can stop. If the gender of the fetus is female, this has to be continued till birth. So, when giving dexamethasone, that will suppress the secretion of fetal adrenals, that is adrenal androgens. The sex hormone secretion will be less. So, virilization of the female fetus will not happen. Yes, if the gene mutation comes negative or the gender is male, dexamethasone can be stopped. So, monitoring, again, these are the investigations that has to be done for a child. We are monitoring on CAH, right? So, serum electrolytes, serum 17-OHP. So, every 3 months they have to come for follow-up and we have to monitor the following. So, now we have seen the chunk of CAH, like 90% of CAH will be our 21-hydroxylase. I hope whatever has been explained is very clear. Now, we will move on to 2 other types and then we will end this presentation. So, next will be the 11-hydroxylase deficiency. So, 11-hydroxylase deficiency is, the defect is further down. So, I told you 3, 21, 11 and 18, right? So, 21-hydroxylase deficiency we have seen. Now, it is 11-beta-hydroxylase. So, in 11-beta-hydroxylase, the conversion is from the first pathway you see. The first pathway is mineralocorticoid pathway. 11-deoxycortisone. The deoxycorticosterone to corticosterone is facilitated by the 11-beta-hydroxylase. So, the deoxycorticosterone is not converted to corticosterone, but still we have this, right? This has some amount of mineralocorticoid activity. Whereas progesterone has no mineralocorticoid activity. That's why in 21-hydroxylase we have both mineralocorticoid and glucocorticoid deficiency. Here, this deoxycorticosterone will still have some mineralocorticoid activity. So, we do not have a mineralocorticoid deficiency in this subtype. What is deficient here? Here, since the 11 beta-hydroxylase deficient here, the cortisol is not formed. There is increase in sex hormones. So, let's see here. In 11 beta-hydroxylase deficiency, there is increase in 11 deoxycorticosterone, which is a mineralocorticoid. Low renin activity will be there. So, comparison of both 21 hydroxylase and 11 beta-hydroxylase, just look at this. So, ambiguous genitalia. What about ambiguous genitalia? Both will have ambiguous genitalia in females. Yes, because even in 11 beta-hydroxylase, the final shunting is going to happen. Sex hormones are going to increase. Adrenal crisis only in 21 hydroxylase deficiency. It's very rare in 11 beta-hydroxylase because 11 this deoxycorticosterol has the mineralocorticoid activity. Glucocorticoid values will be low. The cortisol is not going to be produced even in 11 beta-hydroxylase. Mineralocorticoid is high. Here mineralocorticoid is low. So, they can have hypertension. What about androgens? Increased in both. Sodium concentration decreased in 21 hydroxylase, increased here. Potassium concentration increased here, decreased here. What is a metabolite elevated? Here it is 17 OHP. You take 17 OHP, you can diagnose 21 hydroxylase deficiency. The next 11 deoxycortisol will be elevated in 11 beta hydroxylase deficiency, right? So, the basic difference you should know. Just remember in 11 beta hydroxylase, mineralocorticoid is present and that can cause hypertension. Only there is cortisol deficiency, elevated sex hormones are present. Okay. So, coming to the third type of CAH, this is 17 hydroxylase deficiency. In 17 alpha hydroxylase, in between the mineralocorticoid to glucocorticoid pathway, it is the intermediary enzyme. So, this is not going to convert the pregnenolone and progesterone to 17 hydroxypregnenolone and 17 hydroxyprogesterone. Again, here it is getting cut off. So, aldosterone will be produced. So, there is no problem, right? So, mineralocorticoids are in excess. Again, there will be hypertension in this type. Cortisol will not be there. Glucocorticoid deficiency will be there. This pathway is also not getting activated. So, there are less of sex hormones. So, this is going to affect which gender? Because the adrenal androgens are not going to get produced. This is going to affect the male gender, right? Males will be less virilized and feminized. So, we will see this now. So, the overview I am telling you. So, because of 17 alpha hydroxylase, the mineralocorticoid values will be high, glucocorticoid will be less, adrenal ambiguous genitalia will not be present in females, but it will be present in which gender? It will be present in males because we don't have adrenal androgens. So, males will appear feminized. Okay. So, ambiguous genitalia is present in males, androgens are less. So, basic things just remember. And yes, so in females there is because of the absence of adrenal androgens, only the secondary sexual characters will be absent in females. Males will have feminized genitalia, they will be under virilized. Both will have hypertension. Okay. So, we have seen 21 hydroxylase, 11 beta hydroxylase and 17 alpha hydroxylase deficiency. So, in 21 both mineralocorticoid and glucocorticoid will be deficient. In 11 and 17 mineralocorticoid is normal or it is high. So, we have hypertension and here glucocorticoid will be deficient in both. What about androgens? Androgens will be high in 11 beta, androgens will be low in 17 alpha. So, the enzymes which are starting both with 11 beta and 17 alpha will have hypertension. So, remember that. And which are ending with 1, both will have androgens increased. So, just remember some mnemonics and also very importantly remember the steroidogenesis pathway, and at least these 3 types of CAH if you are thorough, you will be able to diagnose 99% of the CAH cases in your clinical practice, and you will be able to write the same in your exams also. So, I hope I have simplified the CAH topic for you. Thank you.